Cecily Tillman wrote that she's a nurse care manager at Memorial Pediatrics. Thank you, Cecily. Tony, can you unmute and introduce yourself, please? We don't hear you, in case you're talking right now. You also could type in the chat box, if possible. And then somebody just called in right now on the phone. We have no name. Would it be possible for you to introduce yourself? Oh well.
And I'm actually driving in there. I'll be there shortly.
Okay. We didn't catch the first sentence of your introduction, please. Could you introduce yourself again?
Yeah, my name is Stephanie Sund. I am a nurse with Intermountain Healthcare Pediatrics.
Stephanie, you presented last time.
Oh, yeah, right, Stephanie, yeah. And did you say on your way here that you will be coming in person?
Yes, I will be coming in person. Just
thank you, Stephanie.
This morning, getting kids to school issues, you know. But I'd love to be there in person so I can meet more of your folks.
Great. Okay, Erin? No, you don't. Just fine. You just talk.
I'm Erin Shoemaker. I'm the admin for the Medical Home Portal, and I'm happy to be here. It's my first meeting with you guys in person. So. I'm looking at all your name tags. It's just because I'm familiarizing myself in attendance. Okay.
Sorry, I have a little crisis. Sorry, Minty Butters. Oh, no. No, it's okay. Untitled Pediatrics, I'm a care coordinator at the Carbone office.
Jeanette, I'm a care coordinator at Utah Valley Pediatrics Plaza office.
My name is Evelyn. I'm the care coordinator at Utah Valley Pediatrics in the Cherry Tree office.
And I'm Tiffany, and I'm the care coordinator at Utah Valley Pediatrics at the Timothy office.
Me?
Sure.
Angie Vitchins. I'm the director of case management and behavioral health for Alpine Pediatrics.
Lynn Bauer, I'm the services support manager for the Medical Home Portal.
I'm Pat. I'm a pediatric nurse care manager with Select Health Insurance.
I'm Jan. I work at Memorial Pediatrics. I'm a nurse care manager.
Nurse care manager Janelle at Holiday Pediatrics.
Oh.
New.
Oh.
Hi. Hi.
Now I have a nice face with a name.
Yeah. Always good.
Heather Castor. I'm with Wasatch Pediatrics in Draper. I'm at home.
Tay with the Medical Home Portal resources.
Jade with Pediatric Care Management with University of Utah Health Plan and Healthy U.
Suanna Jeffers. I'm a care
But that one, I didn't hear the last part of your introduction.
Oh, University Health Plans.
University Health Plans.
Yeah, and I'm Heidi. I'm the nurse care manager for University of Utah Redwood Clinic.
I'm Andrea Jensen, Utah County Health Department. I'm a certified asthma educator, and I'm the asthma program coordinator for our asthma home visit program.
So I'm the same, but I work with the Salt Lake County Health Department, and I'm the program coordinator for the asthma program.
And it's Brittany
Perry. Sorry, I forgot that part.
We're so informal around here. Come on.
Come, sit in the front.
Yeah, feel free. Fill in wherever, grab some food. Welcome. Well, wonderful. So I do have some sad news and some happy news, but mainly sad news. So Tay Haynes, who's been our resources coordinator for really the whole time that we've been doing this, she's retiring this month. So
yay!
The sad news is that this is her last meeting. So you guys won't be seeing her anymore, but we sure appreciate everything that you've done, Tay, over the years, and the coffee too.
Coffee.
Yeah, I mean, I don't want to, undermine the resources, and she's really the resources of the month powerhouse. She's the one who puts that together, and keeps our services directory up to date. But it's also the coffee, so thank you.
And I want to say that coming to these meetings has been so educational and kind of the heart of what I think we're doing. So I'm really grateful to you and all you guys.
Thank you.
Tay has been very invested in this, and she follows up on everything that she hears here. She often looks for things as a result of hearing what you guys talk about, and brings me articles and points out things that she reads and connects all the dots. And so I do agree that this really is kind of where the rubber hits the road a lot, is right here with this group. So.
What are you going to do now?
All those things, and more.
The travel.
Oh, good for you. Travel and garden and read and all that stuff.
Good for you.
Good for you.
Sounds really good.
And sleep. I'm going to sleep.
That sounds great. You'll be missed. And so Erin will be picking up a number of the duties that Tay has been doing. And in particular, she'll be working with the attendance part of UCCCN as well as helping with the resources of the month and so forth. It wasn't actually super perfect and ideal, but we figured that it's better if Erin can be here in person, so we're going to try and find a way for her to be here at these meetings so she can really put those faces to names as much as possible. And just on that note, it really is helpful if you make sure that you sign in for us. So some of what we do, as I'm sure you guys know, is kind of report back on our activities and need to show that we're making an impact in some way or another, and attendance really helps with that, so thank you. All right, so with that then, let's talk a little bit about some housekeeping. For those of you who are new or haven't been here a lot, there are bathrooms kind of right in the center of the building, so I'm not sure if you came in on the center east doors, which is probably the easiest way to get here, but kind of right there as you walk in, you can just go west, there's some bathrooms there if you need to. Guest Wi-Fi is available on what's called the Blue Zone network, so if you have Wi-Fi, that's available there. And then our recording, this big dot that's blinking on and off, it will go off for good, probably at 10 a.m., so we just leave it there. All right, so we do have some announcements. So, Mindy, to let you know a little bit more about what I was pestering you about, it's really for our annual learning session, and I hope everybody got a save the date email. If you didn't, we'll make sure that we'll get you. So we do this every year. We have a big learning session in place of our regular meetings in the month. We're going to be doing it this year on the same day that we would normally hold this meeting, so Wednesday, March 18th through Wednesday of March. We're going to be at the Doty Education Center in the auditorium. So not too far from where we are right now, hopefully centrally located. The one downside of the Doty is kind of parking, so just be aware. But anyway, it'll go from about 8 to 11:30, and we're really excited that we'll be talking about social determinants of health and the impact they have on children with special health needs. So kind of a hot topic right now, and we're jumping into that too. And we're really excited because we're going to be having a number of people talk from a number of perspectives on efforts that are going on and kind of, understanding a little bit more about what social determinants of health can do negatively and why it's important to pay attention to them, what the resources are out there, what's happening already, what we can learn from and build on, what's easily available, and then kind of that continuum of sort of the ultra level. So we would love to have any sort of practice that's doing some of this kind of stuff at whatever level be willing to be on a panel where we talk a little bit more about that. Maybe talk about some actual cases or cases that are enough real that we can really showcase how where these impacts are and kind of how clinics and other practices and other groups can really come together to help support those families. So we'll have some speakers, we'll have some panels. It'll be informal as it usually is, just a little bit longer, lots of food. So we hope that you can make it. And then, we've reached out to a number of different practices. We know had something to do with toxic stress and some other efforts earlier on, some years ago, to see if they're still doing that and if they can participate. So we'd love to have you guys if you're interested. We do have about 4 other clinics today. Love it. All right, so March 18th, we hope to see you guys there.
You might want to reach out to Wagma Momund. She is the PA at Redwood Health Center, and her and I work with refugees. And they have their own social determinants of health. And so it might be to get her input on it, probably to be beneficial, especially now that Governor Herbert said we want more refugees to come in. And what resources are out there? Redwood does have a refugee coordinator. So I would, Anna Gallegos, to get, I would read, and I will talk with them. I won't be in today, but I will talk with WAGMA on Thursday about this to see if she could come in and talk to them, talk to you guys. But I think it would be beneficial just to kind of hear that, because I think our community is growing, and it's not just. It's becoming more and more diverse as more refugees and second migration comes in. So I think those two would maybe shine a light on some resources out there and things like that.
All the resources in yet.
Yes.
Thank you.
Yeah.
Thank you. Okay, we'll follow up, and if we have questions, we'll just circle back to you. And
Yeah, absolutely. And like I said, tomorrow I will speak with Anna and WAGMA and see if they are. I'm sure they are willing.
Okay, wonderful. Love it. Very good. Okay, so next announcement or question. We are working on our writing letters of medical necessity page on the medical home portal. It happens to be the most hit page on our website. And it gets a lot from all over the country and even beyond. So in that effort, we would really love your input, because we want to make the page as helpful as possible. And you're kind of our target audience there, really. So questions would include, are you guys writing letters of medical necessity? Shaking, nodding heads, lots of nodding heads. Okay, wonderful. Next question is, how often are you finding yourselves writing?
Every day.
Most days.
Okay.
Cut and paste is a beautiful thing.
Just make sure the right name is on it.
Yeah, exactly. That's kind of important. So a template that forces you to check the name would also be helpful. All right. So what kind of conditions are you guys most often finding yourselves? Is there a certain kind of diagnosis or condition that's rising to the top, or situation and need?
My last ones have been wheelchairs. This month have all been wheelchairs and orders for my patients that need the beds and wheelchairs.
Okay.
Synergist, huge.
Yeah.
Huge.
What's that?
Synergist. RSV.
Yeah.
I just because I've been in this line of work for a little while, the University of Utah has Epic, and I've made some smart freezes that will pull in information and drop them, and you guys can. I'll send those to you just as a. But it's the ABA therapy, which is huge in our clinic. Because it is a letter of medical necessity. It's more like a prescription, but both of them are merged, so the insurance can't come back and say. And then I have one for any type of DME. You just plug it in. So I can send those to you as well.
Yes, please. That would be great.
Sleep safe beds are a big one that I see from an insurance perspective. And also anytime a child needs to be seen outside of network, and like a very subspecialist, often we send these children out of state because we don't have the resources here. And so those are the kinds that I see. And you're always welcome to call me and say what needs to be included, because I can send you a copy of the policy for whatever it is that you're looking for to see if the criteria is even met. And if it isn't, then we can kind of tweak the letter to say we're looking for the exception to the benefit.
Okay. So in addition to a template, it would be good to have some information on there suggesting talking with the insurance case manager before you go through the effort of sending it off, because you can get ahead of time and save that round. Lots of nodding heads.
She saves me hours.
Saves us all hours.
Yeah.
Okay, awesome. Oh, that's great. All right. Which are most difficult? The ones that you didn't say the right things in, and then come back around, and you have to do it all over again. It's been hours and But are there things that are just trickier because of the nature of the request?
I think one that I run into a lot, unfortunately, is again with the refugees that are coming in. They're very malnutritioned, and so but they're 11 and 12, and so when we are telling the families that when we put them on like a protein supplement like Pediasure or whatever, insurance will, because they're on Medicaid, insurance will deny it, even though their BMI is either 1% or less than 1%. And so that's been the hard one for me to get approval from, just because Medicaid has those guidelines because they're over age and let's be honest, these families can't afford hardly like a bed to sleep in. So to get food from a food pantry that they're not used to either, right? They're not used to eating our food. And so the food supplement's really hard to get.
And anything that's considered over-the-counter formula, you can have an incredibly complex child with like a glycogen storage disorder or whatever that's on 2 or 3 different formula mixtures and it's working and it's great, but just one of them is over-the-counter. They'll approve those. They'll approve the prescriptive ones, but not the over-the-counter. And it makes me crazy.
Thicket and gel.
Those are never approved.
Yeah.
Yes, but there is a thing you can apply for, and that really helps.
Yes, yeah,
patient take it way down.
Yeah,
where do you apply for that?
For the thickeners, is that what you're saying?
Yeah.
I just did one yesterday for a letter for a thickener. What are you referring to?
I'll have to send. I'll send you guys a link because it's a. I can't even remember the exact name of it. I want to say something like We Care or something like that. But they can apply, and if their financial situation meets the needs, they can get it at a reduced rate.
Yeah.
Okay, I went through that, and this girl said it's really helping.
Yeah, and it's hard too because it is still very expensive, and so we're finding that was one of my unfortunate DCFS calls. The parents can't afford the thicket, so they've been just feeding the child normally, which is aspiration and pneumonia, but that that's definitely a social determinant of health. They can't afford this medication that. Since it's prescribed, technically, should be covered. But any type of gel thickener or thicket or whatever is very hard to get covered.
It is hard.
Yeah.
And I think from almost any insurance, I don't think it's something that
No,
other
it's not
insurances.
just exclusive to Select.
Oh, good, because it makes me crazy too. Go ahead and pay for the ER visit, see
Well,
if I care. I mean, that is the problem.
Yeah,
it makes no sense.
Yeah.
A lot of things about healthcare right now make no sense. So.
Well, this is really great. So what we'll do is we'll gather, what you guys have said you'll send, and we can follow up with you as well on that. And we'll kind of start looking at that again, and then maybe we'll even present you with the draft and some of these templates or samples that we can put out there and get your input for you before we update what's going on there. So, thank you. This is great. Really, really great. And that's what the Medical Home Portal is supposed to be about. So if you guys do go to it and see that there's stuff on there that's either not very helpful, it's not quite right, it's out of date, please tell us, because we are doing it for you and care coordinators like you, and we want it to be useful. So we really welcome that constructive.
We've already took letter for you now.
Good.
The template.
Wonderful. Yeah. Okay, we'll do that. That's our goal. All right, fabulous. Thank you for that. Okay, so a couple of other announcements. So next month, someone from the Developmental Disability Council, DD Council of Utah, will be here presenting, talking a little bit about some research that they've been doing to try and understand accessibility of healthcare services for folks in the state of Utah. And she wanted me to let you guys know of a couple things that are happening now in case they'd be of interest to you. So the first is that there's going to be a roundtable to discuss delegation of services for waiver recipients and others covered by the Nurse Practice Act, and it happens to be on January 27th at 4 p.m. So if you are affected by that, know of someone who would like to provide some input on that, they are very welcome to attend that meeting on January 27th. And we'll put more details about that in our resources of the month. But between now and then, if you want more information from me on that or connected council, just let me know. In addition to that particular meeting, they are doing town hall meetings across Utah, 6 in all. One's already occurred in Salt Lake, but there's a second one in Salt Lake on January 23rd. And then a number of others from Price to St. George to Logan. And they are about the state plan that the ED Council is putting together, which will guide their actions for the next 5 years. So basically to ask what you think your community needs. Of course, this is going to be particularly relevant for those who have disabilities already and see some changes. So, again, this will all be in the resources of the month, so if you feel like you'd like to share this with folks you know, please do. Okay, so just a few updates. We've done, timely, I would say, an update to our asthma diagnosis module, and we've updated our self-advocacy And I wanted to make you aware of one other thing that I didn't get in the slides. So I just was made aware of a new service. So I kind of had been hearing some mutterings about something that the legislature was funding, and it had to do with mental health, and I believe that this is it. So it's called Call Up, and it's through UNI, and basically for primary care practices, family medicine, pediatric practices. If you have patients 0 to 24 years and you need some help with them from a psychiatric provider, like on a phone call, you can now just call up, and there'll be someone who's able to talk to you. There is a little bit of paperwork to do ahead of time to make it a little more smoothly, So let me pull up this email that talks a little bit more about it. Call Up is a free service for any primary care clinician in Utah to use. There will be a child psychiatrist quickly available by phone every weekday afternoon from 12 to 4:30 p.m. to offer curbside consultations on patients 0 to 24, as well as resource agents available during business hours to navigate referrals in your area, regardless of insurance. To save time during the consultations, the program is asking clinics to pre-register their providers with the required demographic data and have the providers take a short survey. To set up this appointment or with any other questions, please call Katie Painter, program facilitator, and then please visit our website at health.org/call-up for more information. So this will go out in the resources of the month. I can send it sooner if you're
Yes.
Okay, I'll send it right after this meeting. I'll share with
Mindy,
the email I got and the.
So Katie's doing it by clinic, so she'll probably send you an email. She'll just want your clinic information and then each of your providers' emails, and then she emails the providers directly, and they fill out a survey, and then you're good to go. So instead of the providers having to take time to go on and sign up on their own and everything, which they don't have a lot of time to do that. So, yeah, they're just doing it by clinic. Our clinic did it. I got all our providers on.
Awesome.
So I think it'll be a good service.
And then once they're in there, they can just call. They're in the system. Their area is known. And they immediately can start moving ahead. So, super exciting. Hopefully, will help a great deal. So they're prepared to consult on diagnostic clarification, medication guidance, treatment planning. So that was good news. It just started January 6th. So we'll send that out immediately after this meeting. Hopefully you guys can get your clinics signed up, get your providers those surveys.
Setting.
Okay. Okay, so now we're into, it's actually Does anyone have a case?
I have a case, but I'm going to need, I think, if I can, did you say Peter's coming? Or no, who's coming to speak? Paul.
Yeah, Dr. Carbone.
Yeah, because mine's in concern for an autistic child that I'm having a hard time with a resource. So.
Should we take advantage of Dr. Carbone being here and you can...
Well, I'd like to. I mean, maybe you guys know, but instead of repeating myself twice, I just think that maybe if he's got some options for me, then.
Great. Okay, well, I'll let him know when I introduce him that there might be some non-SPARK questions for him as well.
Okay.
All right, sounds good.
But she's still autism, SPARK is still kind of related.
That's right. I mean, we're very fortunate to have Dr. Carbone coming this afternoon. Okay, well, let's go ahead and turn the time over to you guys so that you can get your message across. And then if you put it in presentation mode, then it doesn't work for. Sorry. Yeah, I apologize for that.
All right. Well, thank you so much for letting us come to talk to you about the Utah Asthma program. And when I say us, I mean Andrea Jensen from the Utah County Health Department, and she will talk about the homelessness program. And then we have Brittany Perry here. She's from the Salt Lake County Health Department, and she might be able to answer some questions for you if you have questions after the presentation. Okay. And there's myself, of course. How can I forget about myself? My name is Gary Baragoshi, and I will talk about the quality improvement part in the asthma program. So the Utah Asthma program is funded by the CDC. In 2014, we received a 5-year grant cooperative agreement for the Utah Asthma program, and that grant was renewed last year. So the Utah Asthma program vision is to improve the life of those with asthma, and the mission is to make sustainable connections for those with asthma with the following principle. So create partnerships, conduct surveillance and evaluation of asthma, or promote the use of evidence-based practices, be an open communicator, facilitator for open communication, also. So the National Heart Lung Blood Institute, NHLBI, it's always a mouthful, came out with new asthma guidelines in 2018. Those guidelines, they have 4 components. So the first component is assessment and monitoring. So assess asthma severity, initiate therapy, then assess for control and adjust the therapy. That would be the step up or step down approach, and then schedule follow-up visits. The second component is education. The education can be in the form of a written asthma action plan or providing a patient with self-management tools. The third component is control environmental factors. So provide the patients with resources on how they can control allergens and also treat their comorbidities. And the fourth component is the medication. Make sure the patient receives the appropriate medication with the appropriate medication delivery device like a spacer that would really fit or meets their needs. Right. Now UPIQ, that's where I work for. And so what is UPIQ and what do we do? Partnership to improve healthcare. And what do we do? Well, we promote evidence-based practices and assist providers, care coordinators, nurses, and other supporting staff to implement quality improvement. Some of you I have worked with in the past. So we follow the IHI model of improvement. And the IHI, so there's 2 parts in that model of improvement. The first part is 3 fundamental questions. What are we trying to achieve? How do you know that any changes will lead to improvement? And what changes do we actually want to make to achieve the improvement? The second part is the PDSA cycles. Test the changes to determine if the changes are actually really helping us to improve the quality of care. And PDSA stands for Plan, Do, Study, Act. Plan is plan the test. And then also don't forget to plan how to collect the data. It's also very important. And do the test on a very small scale. Study, analyze the results, analyze the data, and then act, review the data, and based on the results, change or roll it out to a bigger scale. Make some tweaks. And here would be a typical UPIQ learning collaborative plan. So usually our projects are 4 to 6 months long, where we are interacting with the practices on a monthly basis, and the interaction can be with calls or webinars or site visits by the UPIQ coaches. And then after the 4 to 6 months, we take a hands-off approach. We leave the practice center alone for 6 months, and then reconnect and ask them to do a track review of the previous 6 months to see if they're able to hold the gains they accomplished during the project. As we know, changes for a short period of time is very easy, but to make sustainable changes, that's a totally different ballgame. So we just finished our asthma program project, QI project for 2019. So we analyzed the data in December. And we had 12 practices participating, and here are our donors. So remember the second questions on the 3 fundamental questions. How will we know that the changes are leading to improvement? Well, measures will help us to tell if a change will be improvement. And there's 3 different types of measures. There's the outcome measures. I see the outcome measures as the voice of the patient. For example, is there a decrease in infection rate? Is there a decrease in hospital or ER admissions? The second measures are the process measures. I see that as the voice of the working system, right? Processes. So where we would do a process mapping to identify gaps or redundancy in the process and then work with that. The third measure is a balancing measure, because we'll make sure that any implemented process has no unintended consequences. Just because I implemented now, for example, the asthma control test in a visit, and suddenly every visit is 10 minutes longer, there will be an unintended consequence. So you have to work around that and another solution. So measures. So here are the core measures. We offered the practices, or we gave the practices last year. And usually we give them 2 core measures, meaning practices have to do them. And then we offer them 2 optional measures. And that's up to the practice if they want to do it. Our focus last year was assessing asthma control by using a standardized tool. And the second measure was did the patient receive an asthma action plan or any self-management tools written in the after visit summary. The optional measures were the patient received a flu shot within the past 12 months.
Sorry, somebody on GoToMeeting is not muted, and we're just hearing some background noise. If we could ask you to mute yourself. Thanks.
And the fourth optional measure is was asthma severity documented. And as you can see, all of those are process measures, and we tell the practices what are the numerators, denominators, and what would be the goal. So plotting data over time, like with a run chart, is a very easy and effective way to see if changes will lead to an improvement. And here would be the results from last year's project, some aggregated data from other practices together. And as you can see, the baseline with using as a standardized tool to assess the control was only 10%, and by the end of the project, actually by February of last year, we achieved the goal. And then we were able to hold the goal, and the 6 months post data showed us that that the practices, not we, but the practices of the gains. I think practices really realize that knowing the control level of the patients is very important for them to get to know their patient population. Also, Andrea is going to talk about the home visiting program. Knowing what patients are uncontrolled with a score, and to refer into the home visiting program. Asthma education, also we started out about 57%, and by the end of the project we were up to about 80%, so that was also very successful. And the flu shot and the severity level documentation, also we did perform very well. The balancing measures, the balancing measures, we sent a survey out in the project, and practices answer that one. And one of the questions we are asking is, how have new asthma processes influenced the job responsibility of other projects? And the majority answered somewhat, but not at all. So which is actually a good outcome, because if you would see a lot of, the majority would see a lot, then we knew that the practices who participated last year were actually all high performers, and we wanted to find out what makes a practice a high performer. Are they ready for QI? Are they ready for improvement? And so we asked them a couple of questions, and what stuck out is, if the practice has a QI champion, it could be a provider, could be a care coordinator, could be anybody in the practice who takes on the project and leads the project, is really excited about the project. And if the practice has previous experience with QI work, it's a good indicator that they might perform very well. And with that, I'm going to hand it over to Andrea, who is going to talk about the Asthma project.
Thank you. Look, I'm so impressed with all of you. I have to say, and I feel like all of you are radar on MASH. You're kind of the brains behind the scenes that keeps your clinic going, and that really keeps things going. So, well done, everybody. It's interesting for me to hear it from your perspective. So, this is our asthma home visit program right now. We're in Utah County and Salt Lake County. And then with our new grant cycle, we are going to be working with two that they're called frontier counties, and they will be only selecting Medicaid patients. So we're still trying to get that up and running. But our programs have been going, this is our 6th year for our program. So I think most of you are aware that asthma is the most chronic disease among children and #1 cause of missed school days. So higher prevalence rate than diabetes, seizure disorders, anything else. And of course, if the parents are missing school, then mom and dad are missing work. So that can cause some problems. Okay. So these are a little bit older stats. Sometimes Department of Health is a little bit lagging in their stats, but you can see how many hospitalizations, how many ED visits, and how many deaths. And I wanted to put this picture up because I just wanted to show you that behind statistics are just people with the tears wiped away. And I've had a lot of tears over my years. Those adorable kids happen to actually be mine. And you'd probably be mortified that I'm showing you their photo. This was years ago. They're in college now. The one in the back is my son Alex. He's 25 now. He was in the hospital 8 times and in ICU twice. He almost died twice from asthma. My daughter in the front there, she was 7 at the time, so she's 20 now. And she was in the hospital 4 times. He was discharged that night. She spent the next day there for her 7th birthday. And her first grade teacher brought her up a cake. But this is real. Just wanted you to see some of the faces behind that. And this isn't something that we're really thrilled about, but Utah has the 3rd highest death rate in the nation from asthma. So why that is, we don't know. We don't know if it's air quality. We don't know if it's elevation. We don't know. We have a lot of rural areas, and there's lack of access to care. We're not quite sure. And as you can see there, Mississippi's #1, then Oregon, and then Utah. And keep in mind, not here in the state, but nationwide, there are 10 people that die every day from asthma. So when all of us go to bed tonight, another 10 people will have died from asthma. And we hear horrible stories about, people that were crawling in to get their inhaler and their family members found them on medication or something like that. They're really, really tragic things. So our program works. CDC provides funding. They want us to align our services between public health and healthcare, which is what we're doing here. We just mesh together beautifully. We know that you only have between 7 and 9 minutes in the doctor's office. Is that about right? And you try to cram as much time as the doctors can in that visit. But that's where we step in, is we're actually paid to, once they're diagnosed, once they're prescribed, once they get started on the education, we can come in and spend as much time as they need in helping with education. In fact, I was talking to a family last night that had been in the hospital. I think their daughter had been in 8 times so far. And I think this little toddler's about 4. And she said, I don't remember anything. I could see the doctor's mouth moving. I couldn't hear anything he was saying. I just wanted to get my child home. And so this is the benefit. We come in after the crisis, and then we're able to help them in their environment. So we provide intense self-management education and home-based trigger reduction services. And I'll talk about what we do. So these are the flyers for our program. They're available in English and Spanish. We follow the 3-visit model, so 3 in-home visits. And then just recently, Utah County, we were able to get approved some video software that's HIPAA compliant, so we'll be able to provide some virtual visits. And I don't know, that's something you guys can check into. So finally just got that approved. We can come during the day. We can come during the evening. We don't want people to have to miss work for this. Occasionally I'll do it Saturday. And then we do follow-up phone calls, as Gabby was mentioning. We want to make sure that this is long-term and that this is sticking with people, and they're not going to their bad habit of improper inhaler technique, and they can't remember anything about when they need to take their child to the emergency room. So after the 3 visits, we call them 6 months down the road and a year down the road, and I can talk about some of the measures that we use. Basically, some of the criteria for this: if a child's been in the hospital, if they've been in the ED, in urgent care, if they've had a course of oral corticosteroids within the last year, or if they have an asthma control test score of 19 or below, all those would be someone that has severe uncontrolled asthma. So these are programs. So that's me, Andrea, and then Brittany. So, and I know, Gabby, you can send out our contact information. And Brittany, I think you brought some flyers for our program as well. So really easy to do. So we have a variety of ways that people will send referrals to us. With Intermountain, we have we're allowed to get on their email system. We have a limited use email, and we can get in and with our password and everything again. Then we have a spreadsheet that's password protected, which they will give us the code to, and then we can get a list of their patients, call their patients. Usually clinics just send us a fax. Then we try to contact each referral 3 times, 3 ways over 3 different weeks. So we'll call them, we'll send an email, we'll send a text, and then we will report back to you. And full disclosure, Utah County, our fax machine, I think is 15 years old. I think they brought it from the old building, and it's notoriously pathetic. So we finally, I was able to get the IT department to put software on my computer so I can actually fax out from my computer. In the past, we really, really had a difficult time, and I know Salt Lake County was a lot better. A lot more funding than we do. But we were finally able to find a way to make sure that we could get that feedback to the clinic. And so we could say, we contacted this patient X number of times and they declined to participate in the program. Or they enrolled, they made it to visit 2 and they dropped out, or they completed all 3, whatever it is. We can provide that feedback to the clinic. Okay, so this is just a little, we have a flip chart. It's, you know, such a high budget here. We go over a lot of different things, so making sure that they understand that asthma is really a disease of inflammation, and that untreated over time can transition to COPD. Even for people that have never smoked a day in their life, about 24% of cases are from COPD, or people that have never smoked but uncontrolled asthma. So we talk about how it works. We talk about controller medication versus rescue inhalers. We have little stickers they can put on their different inhalers so they know which inhaler is which. We talk to them about, I know, I'm hot. Are we turning these down in here? Yeah. Is there a way we can especially those of us of a certain age. Night sweats, you know, the fun. So we talk to them about what the normal asthma symptoms are, and then we have them say, what happens for you? What does your child look like? Because as you probably know, if you've seen one kid with asthma, you've seen one kid with asthma. We know that there's so many different phenotypes and endotypes of asthma now. It's all going to look very different, as will their treatment. And then we'll talk to them about when they need to go to the emergency room. We'll talk to them about the emergency signs. We talk to them about triggers, have them identify triggers, talk to them about an asthma action plan, and we're always referring back to the clinic. Make sure that, touch base with your doctor. Make sure that you have your asthma action plan filled out so you know when, if you need to start on prednisone, when you need to start on that, when you need to go to the emergency room. So we're always referring back. Obviously, we never give any medical advice. So we will check inhaler technique. About 92% of people use their inhaler incorrectly. And there's so many on the market. We have the dry powder inhalers, which are really pushing now, which is really hard for little kids to use, even though they're approved for kids 4 and up on some of them. I think it's a terrible idea, personally. I had to actually get rid of mine. We have our soft mist inhalers. We have our meter dose inhalers. So we check inhaler technique. The chart in the middle there, that's from the CDC. And we have a little check sheet for every single device that's on the market, and so we can check and make sure they're using it properly. We also do have some spacers that were donated to us by the company, for those of you that don't have those for your little kiddos. So when we're there, we always check to see if they have a doctor. So obviously asthma is a chronic disease, and we want that followed long term. We don't want it just to be a flash in the pan and they're getting an albuterol inhaler at the emergency room and no one follows up with them. So we have, for both of our counties, an extensive list of different clinics. If they don't have a doctor that they can go to, either low-cost clinics or sliding scale, some of our federally funded. And I know we have a particularly great clinic in Utah County that actually has a pharmacy in-house. And they can usually get low-cost inhalers there as well. So if you don't have insurance, we have care connectors in our counties that we can make sure that will help them through that. Because I know my oldest son aged off my insurance, and it was a nightmare to sign up for insurance. So we can help them through that process as well. So the second visit is our home-based trigger reduction. So we have a slideshow, and we talk to them about what are the basic asthma triggers in the home, where are they found, and what can you do about them. And most people have no idea that they're simple things that they can do. They can take as much asthma medication as they want. If the cat's sleeping on their bed, if Uncle Joe's smoking, if they wash their sheets every 3 months, if they, don't vacuum, they never change the furnace filter, all those things are going to start to add up. So each participant will give a zipper pillowcase cover. They'll also get a mattress pad cover. And then just in Utah County only, I wrote an additional grant, and we provide these allergy and asthma-friendly cleaning products. We actually teach them how to clean. I thought initially we would just give them the products. Most people have never seen these things and didn't realize that it's better to use the cloth Swiffer, to use a dry Swiffer on their floor. Don't use a broom because you're just going to sweep all that into the air, which you're going to inhale. So we talked to them extensively about all of that and about the MERV reading on their furnace filter and make sure that they understand how all that works. So if they do have a problem, we don't want to say, well, good luck getting your mold fixed for that hole in your ceiling. We'll see you in a month. So both of our counties, Green and Healthy Homes. Is everybody familiar with Green and Healthy Homes? Great program. They have a lot of funding. They can come in. They can take out carpet for people that have asthma. They can install solid surface flooring. They can get vacuums. They can get air cleaners. They'll help them with furnaces, all sorts of things, correct?
Yeah, they provide free shark vacuums for individuals that are on Medicaid, portable air filtration systems that they can put wherever they're sleeping or wherever the child's spending the most time in. And then they also provide all of that as well. And then they do an in-home environmental health assessment. And then they provide a report back to us, and then we're able to follow up with the individual to check on how those things are going. So
it's a great resource.
Yeah.
Eventually we're hoping it was supposed to trickle down to Utah County. Hasn't moved down there yet, but fingers crossed that will happen. But we do have critical home repair loans for Habitat for Humanity, and we have our CDBG funding for cities. That's community development block grants. And so if someone's furnace goes out, if somebody needs a new water heater, if something else is going on, we can help them with that as well. Okay, so on the first and second visit, they're going to make goals. We don't go in and tell them what they do. We want it to be self-management. They want them to decide, well, I'm only going to give them their full rent 3 days a week. I'm going to really try to make sure that they get it every day, and I'm going to see if I can work on that. Maybe for the environmental assessment, I really should be washing my sheets more often. Wash them, once a month if I remember. Got so many beds in the house. Whatever it is, we'll follow up with them on the third visit. We'll review inhaler technique again. National guidelines actually recommend that you review that every single visit with a physician. So we try to do that on our home visits as well. We just don't quite have time on the second visit. We'll repeat the asthma control test score. And I would say probably 90% of the time, their score will go up dramatically between visit number 1 and visit number 3. So the first visit, and then about 2 weeks later, we do visit number 2, and then a month later, we do visit number 3. That gives them time to go back to their doctor if they need to change the medication, whatever they need to do to talk to their doctor about. Also, if they need to get something fixed in their home, we're hoping that gives them time to get fixed. Then we'll come back and see how they're doing on the third visit. There's other things, too. As health educators, I know a lot of people are really unfamiliar with what we do, but we tell people we provide education pretty much in any area of your life that you need. But the doctors and nurses that you would love to provide, you just don't have the time, but we have the funding to be able to do that. So both of our counties, we have free car seat inspections. The majority of car seats are not installed properly. We make sure that they can come to our office, get their car seat installed properly. Way to quit. If we have smokers, we'll have the way to quit line. And right below that little baby step, so that program's only in Utah County, but that's for pregnant moms and their partners. It's a one-on-one coaching smoking cessation program, and they get diapers as an incentive, which, remember back to when your kids were little, how expensive diapers were. Yeah. Stepping on this program in the right-hand corner, we have a lot of seniors as well, and it's a falls reduction workshop. It's a 7-week workshop. We want to make sure that they're safe in all areas of their life, and we talk about removing the rugs off the floor and making sure there's no cords for them to slip on. Something you might not even think about, painting a dark color behind the toilet because they get up during the night to go to the bathroom and they can't find the toilet. So having it a different color than the wall can help. All sorts of fun things. WIC, of course, is one of our great ones. Living Well with Chronic Conditions. Has everybody heard of that? Mm-hmm. Great workshop. The leaders actually have to have a chronic condition to be able to teach it. So we all know that when you have a chronic condition, you sort of have a new normal. So we want to make sure that people know how they can live their best life, and things aren't going to be the way they were before, but they can live a new normal. There's also a Living Well Diabetes. There's a Living Well Chronic Pain class. Those are all free through the State Health Department. They're taught at most of the counties. We also have our senior program. We have our foster grandparents, and you may have seen those in the schools or have friends that do that, and they go in their classrooms and help the little kids with reading or whatever else is going on. And then the Senior Companion Program, they can actually go out and be a companion. They can go visit their companion and play bingo, help them write out the birthday cards for their grandkids, whatever it is. So we help them in every area of their life. We've had kids that have needed speech therapy and all sorts of things that we can help them with. So, is this working? Yes. You can see our statistics here. You can see this bottom right-hand corner is one that we're most proud of. We talked about, let's just let the insurance companies pay for a hospital visit or ER visit if they're not going to give us the medication. 82% is what we've been able to reduce hospitalizations. We have 70% for our asthma-related ED visits, oral corticosteroids, 53%. Up here on the top, 75% decline in missed work days, 53% missed school days, and 60% in unplanned doctor visits. Those urgent care, they got to call that morning and get their kid in really quick. So we do have the data behind that, and our grant is very, very, very competitive. CDC does not give this grant to very many states throughout the country, and everybody wants it. And we were able to get it by showing by our data how effective we are at helping these people. So questions about how the program works?
Do you have any hints? We have a lot of people that are insured, but then when you go to fill an inhaler, it's very expensive. Doesn't seem like, a lot of my go-tos like GoodRx doesn't bring the cost down much. Yeah. Do you have any suggestions? Because I think they're willing to do it.
I do. So in Salt Lake County, I'm not as familiar with your clinics, but in Utah County, there's Lands Community Health Center with the in-house, since they're a federally funded clinic, and a sliding scale. So I'm in the same boat. I have asthma. All 3 of my kids have asthma, so we got 4 of us with asthma. We also have allergies. We also have food allergies, so we got to have our EpiPens. My son was on a biologic, the one that almost died twice. So that's $1,000 a pop. The newer biologics are $5,000 a month. So, it's not pretty. So we understand that. And I know where I work, our deductible is $7,000 for a family. So basically, people are going in and paying $240 for their QVAR. So we have people that are working full-time, and they just can't afford it. So I know our federally funded clinic, people can go in there and get their inhaler for a lower cost. Because basically they have to pay cash for it. So we've used NICU meds in the past when my son was on his $1,000 injections. This was way early 2000s. It was extremely hard for us. Our copay was $125 a month. Doesn't sound like a lot, but times 4 times all the asthma inhalers and the EpiPens and everything else adds up. So we were able to get copay assistance through them, and they paid $125 copay a month. I've heard some of the foundations aren't doing as well, but the federally funded clinics are amazingly. We have families that will say, I'm going to go to Mexico. I got family in Mexico. We're going to go down there and visit them to bring up some meds. And they do. They do that all the time. We prefer they just stay here so they can be followed. So we'll get them into the clinic, and then they'll also fill other prescriptions. If they have high blood pressure, high cholesterol, depression medication, they'll refill all of them once they get the medication. So that's been our best resource. What about you, Brittany, for Salt Lake County?
So there's a couple of different ones, and we hand out like the GoodRx and a couple of different locations that they can go online and look. Sometimes they have luck and sometimes they don't, because it's a working family, and again, they don't meet those income restrictions on all of those government-funded programs. So we have a list of different pharmacies, clinics that they can go to that are lower cost, depending on their area within the Salt Lake County. And we hand those out and talk to them specifically to their area where they're from. So.
Is that something you could share with us?
Absolutely.
Yeah. That would be great because...
And then going online and looking for coupons. My daughter had Symbicort free for a year.
Yeah.
And then I go online, I'm on Dulera, and so mine's about $75 a month. So I have to go on every year to the Dulera website and fill out my little coupon code, and then I can get it for $15 a month. So, coupons aren't just for groceries. You can use them for medication. That's true. As well. Because it definitely adds up, and I get it. I really do. I understand that. And sadly, I've gone without my inhaler before, so I could get it for all three of my kids when they were younger. Yeah. Trying to keep them out of the hospital.
Yeah. It's tough.
But any other questions about how the program works, or? Yes.
Those 2 counties that you're working on expanding into, which are they?
Do you know? I believe one is Central. I think the other is, don't quote me on this, I think it's the Tri-County area.
Real rural areas.
Yeah.
And it's all for those counties. It's specifically for Medicaid individuals that are on Medicaid because their funding is so restricted that they're trying to catch the Medicaid individuals in those counties.
Central is a town.
It's tiny. No, Central's a health district. So that's Richfield, that's that whole area.
Okay.
Yeah, there's
the Central's down there, but it's a tiny, tiny town. That's Sevier County.
Right. So what we go by for public health is we have 12. They're called LHDs, local health districts throughout the state. There's 12 local health districts. Okay. And so Central is that whole area. Tri-County is Vernal and Duchesne, and I think a little town out there. Another thing that we've been working on since the start of our first grant is to be getting Medicaid reimbursement. As a certified asthma educator, I can bill for that, as well as both Brittany and I are certified health education specialists, which is the national certification for public health, and so we can bill for our services. We're just trying to get that set up with Medicaid. So our big goal, it really is to have this statewide. Weber's very interested in this. Some of the other counties are very interested in this. So our goal is once we can get third-party reimbursement going, is to be able to have the other counties jump on board as well. And we'll be doing a training shortly for our new counties. Yep. So yes, love to get this statewide. Any other questions?
I'm the transition person that was on the phone, by the way, Stephanie. My background is inpatient at Primary Children's and teaching asthma.
Right.
But I don't ever remember hearing about this or being able to speak to it to these parents or give them a little brochure about it, because I feel like that would really have reassured them, like, it's okay, someone's going to come to someone can come to your house.
We have a referral process set up with Primary Children's.
Oh, good. Yeah. Okay.
But we do need to touch back base with them because their care managers
have one.
We do have one.
We do.
Have one. Okay,
we do. Yeah.
Especially through the ED, don't you? Because that's what I had read in charts. That everything was referred.
Yep.
And then we try to follow up and see.
And what about when they get admitted, like on the Children's Medical Unit where all the asthma kids go? Would that be helpful? Because I could help get that into there if you want.
Because they automatically qualify. If they're admitted, they're automatically qualified.
It's not hard to qualify for our program. There's such a broad qualification for it that we try to push everyone in. So we try to grab whoever.
We don't care how old they are. We've had 2-year-olds, my oldest is 92. So we don't care. There's no age restriction. There's no income requirement. We don't care if they have none of that matters.
Okay. We'll make sure that Stephanie and Karen.
We just said we'll touch base.
Absolutely, that's great.
That's wonderful. Thank you, and
that's such a great program.
Really good though.
Thinking about some of the rural things that you guys are talking about in the programs is that's probably something that we'll hear about next month on the council process.
She's like, I can't believe you can talk about it. That's crazy.
I don't know how much of the providers know, and there's got to be though, since I work for corporate, there's people that go to these corporate asthma meetings, right? And so there's got to be some doctor or leader or someone who can take it to make sure they disseminate it to the providers.
Because all those pediatrics.
They're very good.
put the gapping medicines out everyone.
So big now. I don't remember too better. I don't even know if it existed.
That's not the cleaning stuff.
Well, I don't know if they have it.
Oh, yeah. Give that information like that here.
Yes, yeah.
So this is Dr. Paul Carbone, and he is overseeing the SPARK for Autism Project. And you guys have been talking about this.
Oh, it's about
6 months ago, maybe?
no, it's just longer.
Longer, okay.
We started 9 months ago.
Great, great. So we'll get an update, and then Paul also wanted to let you know that
Totally not a lot.
Yeah.
Yeah, of course. It's on top of it. This is what I do all day. So if I'm not enthusiastic about that, there's something wrong.
Okay.
And when do you want me to exit?
9:58 would be great.
Okay. So it just gives me an idea of how long you want me to blather. I could talk about this stuff. So my name is Paul Carbone. I'm a pediatrician at the university. I think I've interacted with some of you in the past. It's always nice to talk to care coordinators because you all are the people that help children with disabilities and their families lead better lives. So it's wonderful to connect with you all. Thanks for the work you do. I work with, I guess my research, clinical, and educational interests is in the area of autism. I work with the neurobehavioral home program, which is within the Department of Psychiatry at the university, where we do lifespan work with children with disabilities and a child development program. And I just wanted to briefly, how do I make this go forward? So where I come from in part of my life is, in clinical life, is at the at a place called UDAC, stands for University Developmental Assessment Clinics. And I just wanted to remind you before we talk about SPARK, which is why I really came here, is that we do autism evaluations at this time. Maybe refer to us. Hopefully we've been responsive and obviously love any feedback, positive or constructive experiences. But we are probably the only place where you can get a multidisciplinary autism eval within a couple of states. So we have audiologists or audiology capability, lots of great nurses, occupational therapists. There's a group of 3 pediatricians. We have 3 psychologists, and we're adding 2 more within a few months. Speech and language pathologists. So when families come to us, they end up seeing, a combination of all these folks, and they get a very thorough evaluation that we've worked real hard to make more timely, because across the country there's this massive problem of really long waits to get into autism evaluations, and I'm proud to say as our medical director that I think our time to get in is less than other places around the country. It's not where we want it, and we're still working to make it even more timely. And families are always at the heart of all of what we do.
I brought some brochures for you guys if you want to.
There's some And just to let you know what we're up against, we're a pretty high volume clinic. So there are some clinics that do autism evals, and they're wonderful places. Within the Department of Psychiatry, I work right next door to an autism evaluation clinic, and they do great work, and I think they probably do 3 evaluations a week or 4. So we do about 3,000 visits a year. We see about 1,300 new patients every year. We are a very high volume place. We get about between 20 and 50 new referrals every single week for autism evals, which is really above and beyond what the capacity has ever been. So it's almost like we've been a victim of our own success. We improve our care process, the wait time goes down, and then we start getting a higher volume of referrals. But it's a good problem to have. I tell the staff it's just job security. So we've done a lot of QI. We're trying to decrease wait times and time to diagnosis. We've done that by putting our pediatricians sort of at the front end of the diagnostic sort of train, and I can talk to you about that if you want. We also have a really robust telehealth program. I think we do about 500, and this coming year we'll have done maybe 700 to 800 telehealth visits, so we serve the entire state if it's an appropriate visit. So that's sort of UDAC, that's where I come from. I wanted to plug who we are and make sure you know who we are. Our number, which I was foolish enough not to put on this, is 801-587-2255. I'm sure, hopefully you all know that, but if you don't, we can get it to you. So the reason why I'm here, or was asked to be here today, and I'm thankful to be here, is to talk about SPARK. Have you all heard about SPARK? How many people have heard about it? So it's like about half of you, maybe. Okay. So SPARK is a research study whose mission it is to really sort of spark and ignite research at an unprecedented level in the field of autism. It stands for Simons Powering Autism Research for Knowledge. That's what SPARK stands for. The Simons Foundation is a good funder of research for many, many, many years in the field of autism. Jim Simons is now essentially a philanthropist, and the center is in New York. So it's funded out of their foundation. They've funded really good autism research for a long time. And it's really sort of moving towards this area of precision medicine and genetics. So knowing the genetic cause of somebody's autism right now sometimes doesn't have a major impact on that individual, but where this whole field is going is that it will. Based on the genetic footprint of an individual's autism, that may have implications in the way that their core symptoms are treated. Right now it doesn't, but that's where this is all moving in the area of this precision medicine.
So maybe, and I'm just probably very naive to this, so there are genetic markers out there for autism? Is that what you're saying?
There's about 100 or so genes that have been identified, of which there are variants that are directly causative of autism. So it's a good point. Sometimes I talk to families, and they, I'll say, so what do you think causes autism? And I'll get all kinds of interesting answers. But many families are surprised to know that we can identify the cause of somebody's autism. If every individual with autism got all the genetic tests that we would like to do, we could probably identify the cause, depending on the individual, between about 30 to 40% of the time, which is pretty amazing. It's just not a story that's been sort of publicized as much. Like vaccines cause autism. They're really cool. And it's been,
well, do you have issues getting that covered by insurance if you want certain tests done?
I'm sorry?
Do you have issues with insurance wanting to cover certain tests because it's too rare?
Yeah, so SPARK is a research study, so it's different.
Sorry, I'm jumping ahead. Sorry.
Ordering genetic tests through a commercial lab, but we work at UDAC since there is a recommendation that all individuals with autism be offered genetic testing. So I'm the chair of the American Academy of Pediatrics Autism Subcommittee, and we just published the clinical report on autism this month in pediatrics. It's about 50 pages and 600 references. So I'm sure you'll go out and read that right away. But we were very mindful when we wrote it because all of these recommendations are used by insurers to determine what they do and do not cover. It's spotty whether genetic tests are covered, but many do. The devil is always in the details, though, so families sometimes have large deductible plans and things of that sort, and so you may be on the hook for some of the costs, but yes. So we offer that as a part of the package of services that we offer at UDAC. SPARK is sort of above and beyond. It's a genetic test called a whole exome sequencing, and that one is less likely to be covered, but it's very comprehensive. So yeah.
But it's free.
To participate in SPARK is free.
Yeah.
And you get $50 in Amazon gift card. So I always tell people, well, you got a Christmas present for somebody. or a late Christmas present. You get the Christmas present that you didn't get.
But that is for children that have already been diagnosed with autism, not being worked up for it, correct?
Yeah, if you have a professional diagnosis of autism, which is a pretty loose term, but it's not like families have to provide all the documentation online that their child has autism. If you've been told by somebody who is a professional that you have a diagnosis of autism, you're free to participate.
My son was diagnosed with PDD back by Dr. Peck years ago. And so we got the SPARK. We've started this process. We're waiting back. And it was just very much, have you been diagnosed with autism? Yes. It's that, I didn't have to submit any paperwork, nothing. It's just a mark. Yes. Yeah.
Thanks. So, and this is sort of, it's a sprint and a marathon with SPARK. So we want to do this and ramp this up as rapidly as possible in terms of getting the necessary genetic information to researchers to work with so that more genes can be identified and that we can move towards making this information meaningful for families. So that's the sprint. The marathon is that SPARK is not going away. SPARK is a longitudinal study. So the plan is to enroll families when their kids are kids, and then to continue following all these families into when their kids are adults. In fact, adults can participate just like kids can. There's no age limit on SPARK, but it's a longitudinal study. So the material and the knowledge gained will continue to be used for years to come. And everybody in the autism community is invited to join. There's a strong genetic component to autism, which I've told you about, and that's the sort of, it's not as sexy to put, it doesn't fit in the New York Times headline like, there's a strong genetic component to autism, which is a polygenic risk, which is not directly easily identifiable. There's lots of genes that confer risk, but they're not always causative. I mean, it's just tough to convey. But there is a very strong genetic component to autism. But we don't understand all of that genetic risk right now. And so it's important to sort of ramp up this knowledge. And that's why SPARK exists. So the way to do this is to recruit large numbers of patients. A lot of the causes of autism that we found are sort of monogenic causes, meaning that you find a variant of one gene that is highly penetrant, meaning that when somebody has that variant of gene, they almost always have autism. And so those genes have been identified. Where a large group of people with autism, where their etiology lies, is when lots of genes throughout their genome sort of interact with one another, along with maybe some environmental risk, and they all act together, and then that leads to autism. That's a lot harder to figure out. So you need a massive database to do that, so that's what we're doing. So it's a significant amount of data. And SPARK is really relying on tens of thousands of families and individuals. The goal is 50,000 individuals to be recruited into SPARK, 50,000 families of individuals with autism. So I think right now, Gabby, Gabby's got her finger on the pulse of the number of kids, but I want to say it's about 20,000 families have already enrolled in SPARK. So it's been ongoing for 3 years now. I think I went the wrong way. Okay. So there's about 31 clinical sites across the nation that are recruiting families into the study, and the University of Utah is one of the most recent clinical sites. I'm the site principal investigator. Gabby's one of our site coordinators. So we're trying to get the word out about the study as widely as possible, and you all have all this interaction with families, so that's why we're talking to you all today. So this gets to some questions that I had earlier. Who can join? So individuals with a professional diagnosis living in the U.S. SPARK knows that it's not the best situation to only have English-speaking families in the study, but only English-speaking families can be in the study at this point. And that hopefully will change soon. They listen to sites. We've all told them that. It would be great to have more diversity in the data set. So they're working on it. But right now it's English-speaking. And then people are invited if they are the parents of that individual with autism or siblings. So families are being enrolled into this study. So the way you join is really simple. You go to this fancy schmancy, easy to navigate website, which is sparkforautism.org/Utah. And if you just go to sparkforautism.org, you'll still get to our website. And then you provide some contact information. The person who is enrolling, if the parent is the guardian of a child with autism, they would be the person enrolling in the study, and then they provide the information, they assent for their child with autism. And then you sign a bunch of consent forms like we all do for everything, and you're basically signing to share some data, which is all de-identified. So you get a GUID, Global Unique Identifier number. So that number is attached to everything that the family submits, so you can confidently tell the families that their personal information is not attached to anything that the researchers see. And then a second part of the study is the family agrees to share some genetic material. And the way that's done is in the form of saliva. So you get to spit. So Gabby's going to, right on time, show you one of the spit. I tell families it looks like Ancestry.com or
right. So
those things.
The family will get a package like this with 3 or 4 tubes in it, and it really doesn't take much. If you look at the tube in the beginning, it's like, holy smoly, I need to fill up the whole tube. But no, you only need about a teaspoonful. Good loogie. Put it in there, and then send it off. You close it and then you send it off.
Spit happening. There's all kinds of books around spit. But basically, you have a spit party, and you fill those up with just a teeny bit of saliva, and then they're shipped back, and that's basically what the family does. So this does not have to happen in the clinic. It does not have to happen anywhere else. The family does this all online and in their home. No cost, and you get a $50 gift card. And I'm mindful of time here. So SPARK has already doubled the number of genes that are causative of autism discovery-wise, and that's accelerating rapidly. So that's why we're trying to get more and more families in the study. All these samples are reanalyzed every year. If any of you look at genetic testing results, a lot of times you'll see these things like it's a variant of unknown significance. So everything is rerun every year because one year something is a variant of unknown significance, and then it reaches significance, and then the family's contacted back and said, no, this is actually an autism gene. If a genetic cause of the autism is identified, there's various programs called SPARK Searchlight is one of them, where they cohort a bunch of people with the same type of autism who might participate in a trial. So that's already happening with one form of autism where there's been a drug developed for that specific genetic defect. So those things are opportunities for families. Also, there's this thing called Research Match, where we researchers who are in the network, if we develop a research question, we can push out survey opportunities or study opportunities to families. So families get a lot of content pushed to them that they can decide not to read if they don't want to, just in the form of emails, or all kinds of really cool stuff like webinars on the science of autism and things of that sort. These are all some of the best scientists in the country that are doing this work. So you can be reassured that this is not, gobbledygook that's being pushed to families. That's our website again. Please refer any and all comers. That's our contact information. You can call us. That's about everything I have, I think. So what questions are there?
I maybe just didn't quite get it the first time, but sometimes when I read the histories, I represent Select Health from a pediatric perspective, and so I have a different take on what I'm seeing, but I do refer my kids that I manage that I know have autism to this site. But the thought just occurred to me, okay, they have a diagnosis of autism, but they also have a diagnosis of ODD or Downs, and the list continues. Does it matter? As long as they've just said, we think you have autism, good enough.
So it's a good question. It's asked a lot. So I have a lot of folks who have tuberous sclerosis and they also have autism, or Fragile X syndrome that's the cause of their autism, or even if they've identified the cause of autism. This child has a 15q11 duplication syndrome that we found through commercial testing. Can they still participate in SPARK? Absolutely.
Okay.
We still want those families. Because you'll get a sequencing test, which goes above and beyond what most of the families have already had. So you'll learn more about that gene that was duplicated with that microarray test, perhaps they had. So you'll learn more information. So yeah, we want anyone and anyone. It doesn't matter if they have Down syndrome or anything else. Yeah.
So what happens after I get my results for my son? And I guess that information is not shared with his PCP, correct?
It is. The families opt in when you probably remember when you register for all this, you had the opportunity to identify any healthcare provider that you would like to get the information. So when there is a positive test, the results are shared with me as the site PI and any professionals that were identified by the family. And then they SPARK contracts with a genetic counseling firm that then can get on a phone call with all the parties involved and let the family know the results and then what the implications are and what the next steps are.
So I guess my worry was that once we get this, we'd have to try and see a geneticist at Primary Children's because that's closest to us. We all know the wait to get in there is a little long. So that was just how...
Yeah, so the SPARK has genetic counselors. Sometimes geneticists are obviously, hopefully not some of them are listening to me today, but they're incredibly helpful, but oftentimes they're on the diagnostic end of things. Right. Once there is a diagnosis, they certainly have a lot to offer, but a lot of times at that point it's a genetic counselor that you need in terms of what are the risks now for other folks in the family, who else would be recommended to get this tested, what's known about this genetic. A lot of times that can be done really effectively by a genetic counselor. So we have genetic counselors at the U that don't have as long a wait to get into. And
your meeting has ended.